Well, good afternoon, everybody, and welcome to all of you who've joined us for this online media briefing. I'm Lyndall Byford from the Australian Science Media Centre. So the Doherty Institute-led modelling consortium has updated its advice on the national COVID plan, and today's briefing is really a chance for you to try and get your head around what that modelling actually means and directly ask some of the modellers behind that data the burning questions that you might have. So joining us online today, we have 5 of the experts who worked on the modelling. First up, we'll hear a short summary from Professor Jodie McVernon. Jodie is Director of Doherty Epidemiology at the Doherty Institute. And then Jodie will be joined by 4 other modelling experts to answer your questions. So also joining us today, we have Professor James McCaw from the University of Melbourne, Professor Nick Golding from the Telethon Kids Institute and Curtin University, Dr. Freya Shearer, who's a Senior Research Fellow at the University of Melbourne, and finally, Dr. Michael Lydermore from Monash University. So there'll be an opportunity to ask your questions at the end of Jodie's presentation today, but if you think of a question while she's speaking, you can pop it into the Q&A box at any time. So the Q&A box, you should see that at the bottom of your screen, and please remember to use that and not the chat box, which looks quite similar. Or you can raise your virtual hand and we'll unmute you during the question answer time. If you've joined us over the phone, you can also raise your hand over the phone by pressing *9 on your dial pad. So that's it for the housekeeping. We will begin now with Professor Jodie McVernon. Over to you, Jodie.
Thanks very much, Lyndall, and thank you all for coming today. We obviously have quite a turnout online. So I'm going to just briefly summarise what our previous work said and what it meant, and how this next phase of work has bridged from that, I guess, to perform a sensitivity analysis on that advice. So the first piece of work that we were asked to do to support the national plan for transitioning to living with COVID-19 was to investigate a range of different vaccine coverage thresholds at which we could be more confident of being able to open up Australia and start to reconnect with each other in the outside world. And while there was a lot of discussion, and has been a lot of discussion out there about this concept of herd immunity and what vaccines need to achieve, most of that discussion has been about something called the extinction threshold and trying to keep COVID zero forever. So when we are thinking about what vaccines do, we are not thinking about this binary definition of herd immunity, whereby we get to some level and we have no COVID, and below that we have a problem. What our work shows, and what we understand as vaccinologists and epidemiologists, is that every vaccine helps to reduce transmission. And even if there is transmission, the fact that people have been vaccinated means they're directly protected against developing severe disease. And our work was looking to define levels of vaccination at which we were more confident that even if there was circulation of COVID in the community, that we could manage that within our existing capacity. What we showed was that even at very high levels of vaccine coverage, we won't stop COVID in its tracks. We were seeing at the time, back in July, many countries reopening to freedom days and seeing escalating case rates in consequence. So one of the things our work strongly advised was a precautionary approach, where we saw vaccine as a really important tool to get us out of our zero COVID objectives and this no community transmission goal that we've had. A very important tool to do some of the heavy lifting that so far has only been able to be done by test, trace, isolate, quarantine, our public health responses, and by public health and social measures and restrictions that have been imposed. They've been our 2 tools for the last 18 months. With vaccination in the mix, it can do more of that work, but we are still going to need a balance of now 3 components to control disease moving forward. Now, our original report looked at outbreaks, assuming that there was no COVID, and saying, what if we seed with, and we had 30 cases of unvaccinated people seeding these outbreaks, which made sure they took off, and we could compare how epidemics grew. And in that situation, as I say, we ended up recommending thresholds of 70 or 80% as being more stable situations. And again, with these other measures in place to keep cases around the control threshold. However, since that time, we've seen states, we've seen Victoria and New South Wales, and ACT also has established transmission, and particularly those first 2 have many more cases than in the 10s. And so we undertook a sensitivity analysis where we seeded our outbreaks at 70 and 80% with hundreds or thousands of cases. And when we say hundreds, it was 300 to 1,000, and with thousands, it was 1,000 to 4,500, and said, if we start with this many cases, do we kind of break the assumptions? And overall, our conclusions were robust. However, there was one important distinction, which was at the 70% threshold, starting off with thousands of cases, meant that in this window, because in all our simulations, vaccine coverage was ongoing, in that window between 70 and 80%, when the system was more robust, we did see that there was the opportunity for cases to grow more rapidly in that window, and that led to what we call overshoot, that the ultimate size of the epidemic was bigger in that situation. So the logical conclusion, and map back to our earlier recommendations, was that jurisdictions should look at the situation they're in. They should look at how their infections are being controlled with the measures they have in place, and that those who are coming into the 70% mark with thousands of infections should aim to keep case numbers as low as possible by continuing to suppress epidemic growth. And we showed how medium restrictions could continue to do that until they got at least to the 80% threshold. So the overall transition plan remains constant, but there has always been flexibility for application of local or generalised measures to control growth, depending on the local situation, and that was our main finding here. The other ways to reduce the impact of epidemics, so we looked at these measures for comparison. We looked at them with these what we call partial TIQQ responses, which were mapped back to what we saw last year in Victoria at the height of the second wave when the system was stressed. If we can keep more effective TTIQ responses going, then we can keep case numbers lower. If we overlay social measures, we reduce infections again. So it really is this really important message of a synergy of controls. And we also make it very clear that, you know, our model is a high level abstraction. We modeled a single national epidemic with even vaccine coverage across Australia. But in fact, you know, we are states and territories. Within states and territories, we have cities and regional and remote. Within cities, we have, you know, local government areas and subpopulations, and we look around us in Victoria and New South Wales. We see these things play out locally. So our very strong message is that jurisdictions should aim to really optimise coverage in small pockets and populations, because we've seen elsewhere that where there are pockets of under-immunisation, infections can still spread. So really, to achieve the best goals for all Australians, we need to ensure equity of programmatic vaccine delivery, but also then thinking about how these other sets of interventions will be applied and used locally in the future to protect all of the population. So I'm going to leave it there. That's my message on what it is we do and what we said, and we're very open to any questions from all of you. And I think I get to be the director to different members of the team as well. So thank you.
Thanks very much, Jodie. So yes, now is the time for you to ask questions. If you have any, you can ask them a couple of ways, either popping them into the Q&A box, which you can open by clicking the Q&A button at the bottom of your screen, or you can raise your virtual hand and ask them that way. Again, if you're joining us over the phone, you can do that by pressing star nine on your dial pad to raise your virtual hand that way. And if you are asking a question, can you please remember to include your affiliation, so which media outlet you're working for. So let's kick things off. We'll start with, we've got a couple of hands raised, so we might start there with Sarah Martin. So Sarah, we will just unmute you. Go ahead.
Hi there, Jodie. I just wanted to ask about whether the easing of restrictions that has been outlined by both the Victorian and the New South Wales government meet with what you suggest are strong suppression measures between that 70 and 80% coverage, if that makes sense.
I'm happy to take that one. I mean, obviously individual jurisdictions are doing their own modelling. They're doing exactly what we said. They're looking at their local situation. They're looking at the measures they have in place, and they're looking at how their case numbers are tracking. So within those principles of a, you know, three-pronged approach, they've developed up their own assessments based on situational assessment, and are looking at the safest ways to ease up on social measures and minimise the risk of rebound. And I imagine they will continue to monitor that situation as they go to be sure that it's working as anticipated. But it's been great, you know, for example, in New South Wales to already see case numbers starting to decline in highly immunised areas. And that should give us confidence that these vaccines actually work. there's a reason we've given to the population, and this is why we can begin to move forward, because they're giving us a way through and beyond this situation where we've had to go into lockdown with very low case numbers to be able to control transmission.
Thanks very much. The next question is from Daniel Sutton from Channel 10, very similar. New South Wales is going to be reopening first at 70% double dosed. Given your updated analysis, do you believe the New South Wales government plan to reopen goes too far?
I'll let someone else answer that. Does James or Nick want to answer so people don't get bored with me?
I can make a broad statement, and then Nick may be closer to some of the detailed data in New South Wales. But I'm not going to give a direct answer about whether or not it goes too far. I don't think that's really our position. What's more able to say is that New South Wales is not having a complete open up Freedom Day, just as Jody said in the introduction. We don't recommend that, and I don't see any evidence that that's how states are approaching this, and that's very important. So all of the discussions in the New South Wales and Victorian roadmaps are about a stage step down of restrictions and an enabling of movement and behaviours, particularly among vaccinated people. And that's compatible with the work that we've got and the work of other groups as well.
Nick, did you want to add anything?
Yeah, I'll just add to that to explain kind of how we're approaching adding in the different types of restrictions in the model, because what we're not doing is plugging into our model kind of a prescriptive assumption about how different particular measures will affect transmission, because I don't think any modeler can really get a really good handle on exactly how each measure affects transmission, because it's modified by human behavior and people behave differently different times in response to these things. So what we did was to estimate the levels of human behavior and how much transmission they would cause at different times during the previous pandemic. And so for our medium PHSM, which was kind of discussed in the interim report, that is roughly equivalent to kind of the level of population behavior from the start of the New South Wales lockdown, so before all the extra kind of more stringent measures were brought into place. But really, we're not saying that you should go back to how it was at the beginning. We're saying that the level of reduction in kind of population mixing, for example, and other behaviours should be kind of equivalent to that, to meet that kind of impact on transmission. And so I think, as Jodie and James have mentioned, we really need to track that. And so we're working with New South Wales to do so, and to keep an eye on exactly what's happening in terms of behaviour and in terms of transmission. And that's really what should be guiding the health departments.
Fabulous. I'm just going to take one more typed question, because it's on a similar vein about human behaviour. This is from Heather Saxoner from the Australian Doctor. How realistic is it that people will comply with medium PHSMs, given lockdown fatigue appears to set in, especially in states like Victoria?
Freya, do you want to talk about behavioural surveys and maybe how that might map to this understanding?
Yeah, I can start that question, but I'm sure Nick can also have things to add. Yeah, so we've certainly seen behaviours fluctuate over time in the behavioural surveys that we conduct on a weekly basis in the last 12 months. So under any given level of restrictions, we can see different levels of reductions in population mixing, and sometimes after those measures have been in place for a long time, we can see waning. We've seen evidence of waning in those behaviours in the past, and so we would expect that we might see those signs again with current restrictions. But there's it's also hard to interpret sometimes those fluctuations, because we've also seen restrictions in place over winter, and we've seen weather become much nicer in September, October, around the same time that those restrictions have been held in place. So it's possible that people are venturing more outdoors and things as well, and it's hard to disentangle those two effects that we're only sort of measuring the change in behaviour.
Yeah, I'll just add to that to say the impact on transmission that we saw from the first national lockdown in March of 2020 was much greater in terms of the reduction in kind of population level behaviours that we saw in the kind of Victorian second wave. And that's really because everyone went over and above what I think the restrictions were. A lot of people kind of stayed home for a long period of time. And so the level of kind of stringency of the restrictions doesn't necessarily dictate what happens. But I think the the issue there, particularly at the beginning, was that people didn't really understand what lockdowns were, how long they would take. And I think people have probably settled more, particularly folks in Victoria, into an experience of what it's like to live in lockdown. And so, I'm hopeful people can persist with those for as long as is needed to get these vaccination rates high enough, because that's the real aim, is that we wouldn't expect these things to hang around for too long once you get the vaccination levels up really high.
Thanks, Nick. We're going to go to Rachel Clune now, who has her hand up. Go ahead, Rachel. Oh, I just unmuting you. Hang on one second. There you go.
Hi, can you hear me?
Yes, go ahead.
So my question is kind of similar to the last one, actually. The updated analysis say that these strict lockdown measures are not going to prevent the Delta variant from getting into every state and territory, and people are going to get fatigued with these lockdowns. Is that a bit of a warning, I guess, to some of the states and territories that have had really strict border controls, that they're just not going to be able to rely on these sorts of measures to keep it COVID zero? Are they going to have to learn to accept a level of coronavirus in their communities?
I think what we're saying is, we've had amazingly effective border measures in place for a very long time. We've had, those controls, while they've been much discussed, have been extremely effective at keeping Australia COVID safe. And we've seen that short, stringent lockdowns were able to extinguish a lot of other strains, but Delta is really hard. And so, those statements are just a reality check that this state can't be maintained forever. And so our main message there is really encouraging high population vaccine uptake, encouraging an awareness and acceptance of the fact that some degree of social measures are going to need to continue in the future to keep populations safe. And in fact, the only reason, the border controls have been great, but the real reason Australia has maintained its COVID status is the cooperation of the population. And yes, people are fatigued, and yes, people are tired, but we also see population behaviours change in response to awareness of COVID. We had a much bigger problem with vaccine hesitancy a few months ago than we do now. As people are aware of the disease, they see people who are affected. And so the level of public concern and awareness also changes, and we see differences in population behaviours across states and territories that have and haven't seen COVID. Even when restrictions are off in Victoria, we stay a much more sheltered little cohort, with our Emily Dickinson reclusive behaviours than the other states and territories do. So, these things have short-term and residual effects. And I think, over time, we'll see how the balance of that plays out.
Can I just add one little bit to that? And I note that we're moving away from what our Doherty report modelling shows, but into an area where many of the people, my colleagues on this call, actually do a lot of work as well, which is that monitoring the situation and understanding it. So it is definitely the case that with those states which are currently COVID-free, that the best way for them to make a transition is to get vaccination rates as high as quickly as possible. I know that's a very simple, obvious thing to say once you say it, but it is actually the strategy. And why, as soon as those vaccine coverage levels increase in states like Western Australia and South Australia and Tasmania, the chance that the virus will set foot in that community goes down a little bit. So it says that it would then take longer for it to establish itself in those communities or those states. It eventually will certainly establish itself, but the higher the vaccine rate or coverage, the longer that will take, and the less the consequence once it gets there. It'll spread more slowly, it will be more controllable, everything will be better off. So the sort of strategy for those states is still basically the same as the strategy for a state like New South Wales, which is increase vaccination rates as quickly as possible to enable the rest of the public health system to be as most impactful as possible.
Thanks very much, James. We're going to go to a question now from David Mills from News Corp, and he said this is for Professor McVernon. Some postcodes in Sydney now have single-dose vax rates in excess of 90%. Do you think a 90% double-dose vax rate is nationally feasible? And if so, how soon could we get there? And what would the likely outcome be in terms of outbreaks? What would life be like at 90%?
So within our simulation model, we explored introductions at 50, 60, 70, 80%. We didn't explore it at 90. In our simulation, vaccine rollout continues past 80% to around 90%. And that's obviously really important in the final control of disease in terms of who is left, who is unvaccinated. And, we expect that we will see some vaccine breakthroughs and people will still become infected because the vaccines aren't 100% perfect. So effectively, where our scenarios end up incorporates that with being clear that those percentage coverage targets are for the 16 plus population. So that's the other important thing just to point out. But, we expect to see disease control, but because we know that coverage won't be completely even, this is why we keep cautioning against the potential for pockets of disease to occur and the need for attention to those communities to make sure that public health responses are effective, that we continue to support vaccine uptake, that we continue to work with vaccine hesitancy and make sure that we get the most equitable outcomes for all.
Thanks very much. We'll go to Rick Morton now. Rick, you have your hand up. We'll just unmute you and then you can go ahead. Go ahead.
Hi, Rick Morton here from the Saturday paper. Thank you everyone for putting this on again. It's very valuable. I know this is probably more based on clinical indicators, but was there any sense or attempt, I guess, to try and get a handle on the pressure that would be put on an ambulance system or paramedics, or how many people with COVID infections would need to use ambulance services as part of this modelling? I don't think so, but I just wanted to check.
I can answer that. No, sorry, Rick.
I thought that was the answer, but I just need
Yeah, no, our clinical pathways model looked at, we look at certain things in terms of what might happen in terms of capacity, but we haven't explicitly considered those services, no.
Thank you.
Thanks very much, Rick. We'll go to Casey Briggs now, who's also got his hand up. So we'll just unmute you now, Casey.
Thanks, Lyndall, and thank you all for putting this briefing on again. Very useful. Obviously, there's a lot of modelling out there being commissioned by various bodies, and they've come to varying conclusions. There's a lot of uncertainty ahead, I think is a pretty reasonable thing to say. But I wonder, with regards to your model, I just wanted to ask if you've done any kind of examination back on how the estimates for the effect of various measures on transmission potential have performed in the kind of weeks and months since that model has been published. Have you seen anything in the real world, in the observed data that could cause you to rethink any of the estimates for the effectiveness of, vaccination levels, the various public health social measures, and I'm also interested in the effect of test, trace, and isolate and quarantine, kind of in the context of the New South Wales outbreak at the moment, and the estimates for how effective that partial TTIQ would be. Have you looked at any of that?
I wanted to throw to Michael, but I think I'm going to throw to Nick first. Freya.
Yeah, sure. So it's worth saying that the estimates that we used for the impact of public health and social measures and the whole transmission potential is, estimated from the entire pandemic that we've seen so far. We've been doing this since the start and constantly kind of fitting to that data and seeing how it's performed over time there. And so we continue to do that work. So we're continuously taking that same model and interrogating how well it kind of matches the data currently. Your specific question there about TIQQ, so test, trace, isolate, quarantine, how that's changing. I'm not entirely sure how much of the New South Wales data is in the public domain, so I probably can't give too detailed an answer there, but I'll say that some of us on this call, working very closely with the University of New South Wales, Doherty Institute, have been advising New South Wales Health with some modelling, and particularly looking at that question and looking at the impact of essentially the large number of cases on changes to the ability to turn around interviews for the contact tracing, and the impact of that on kind of the durations, the distribution of times from infections to putting people into isolation, because that's what really drives the impact on transmission. So we are tracking that, and I would say that it does all seem to be kind of in line with what we're thinking about. But the next piece of work that we're doing for national modelling is really focused on trying to understand that system more. So we used in this modelling not assumptions about contact tracing and how it works, but kind of the output of that, the data on how it has performed in New South Wales previously. when they were able to keep a lid on cases around the Crossroads outbreak and the end of last year. And then we used data for Victoria as this kind of alternative partial case, but we're now looking more closely at understanding how these things will scale as cases increase. And so we're feeding that back. That's, not something that we can talk about just yet, but that's, part of what we're doing. So we're constantly assessing these things and feeding back, modeling based on that.
Thanks very much. All right, we'll go to some written questions now. One from Stephen Tong, who's asking, has the contribution of schools opening and closing been included in these models?
Not expressly, no. We don't model schools particularly in these models. These are more high level, but obviously school closures are part of bundles of the public health and social measures. And within that bundle, their effects are captured. It's been very difficult anywhere in the world, I think, to disentangle school closure from other interventions that's usually employed at the same time. But obviously in Treasury, thinking about the economic implications of these bundles of measures, school closures have a very big impact.
Thanks very much. The next question is from Natasha Exelby from 10 News. She's saying, can the Doherty findings and recommendations be applied to individual states? New South Wales is doing that, but Victoria says it needs its own state modelling. Given that Doherty is a national plan, is there a reason it wouldn't apply to Victoria?
Michael, do you want to have a go at that one?
Well, it is a national plan, but if you think about implementing it at a jurisdiction-specific level, like in Victoria or New South Wales, you need to break down these bundles of measures into their component parts. And New South Wales has done that without commissioning their own set of modelling, and it appears as though the Victorian departments have commissioned their own modelling to look at those specific pieces of the PHSM program and work out which ones they can turn on and off where. I think overall, all they're trying to do is understand which parts of a medium measure can they turn on and off where and how that's going to flow on down. So I think it still does apply at a jurisdiction-specific level, but when you get right into the details, you can see why individual places might want some more detail.
Thanks very much, Michael. Now over to Jason Gale from Bloomberg. He's asking, the TGA recently approved rapid antigen tests. Should we expect to see them put in place as public health tools, and how would you see them best used? Can you illustrate some appropriate scenarios?
I can take that one unless anyone else wants to. Do you want to, James, or are you happy for me? Yeah, look, so this is obviously, a really important thing moving forward. We're coming from a position in our COVID experience where we've had very low prevalence. We've needed very high sensitivity tests because a big issue in the past has been that we don't want to either miss cases or have so many false positives that we're overreacting to things. And these rapid antigen tests are not as sensitive or as specific as the gold standard PCR tests that we've been using all the way through. But we're obviously looking around the world and looking at how these tests have been used as a risk reduction measure. So in a setting where we're not in a zero tolerance framing, where we have a risk reduction framing, people are obviously looking at how antigen testing can be used to support continuity of services in the community. How can people in different workplace environments that are at risk, use different types of testing to support being able to come to work and keep workplaces open? We're seeing in the UK the use of rapid testing in schools to help to keep schools open. And so I think all of these potential uses need to be observed and interrogated and considered for their appropriateness to our context. And again, it's part of this recognition that things like rapid antigen tests are then going to be devolved as a responsibility to employers and individuals and school communities to help support their own functioning, as opposed to all of this being part of the sort of a national surveillance strategy and testing. So clearly these things need to be done within their license indications. They need to be done safely and proportionately and usefully. And there needs to be a clear framework about how it can be done. But, it's all part of the living with COVID as we move away from this as a public health crisis to a kind of societal, expectation and a COVID normal and a new normal, and thinking about how we can best keep our societies and communities safe moving forward.
Thanks, Jodie. James, did you want to add anything or?
No, I was going to, no, I don't have anything to add. I was going to say something very similar.
Excellent. Okay, we'll go over to Sue Dunleavy now. So you should be unmuted, so go ahead.
Hi, Sue Dunleavy from News Corp. When we get to 70 or 80% and start to reopen, and I suppose at 80% is my question, will we still need to be wearing masks, particularly indoors? And do you have a view on when, you know, you'd be recommending we don't need to bother with them anymore? And secondly, some alternative modelling has suggested that if we do open up at 70 and 80%, we could see, you know, a second or third or fourth wave, and that would see hospitalisations peak around Christmas time. What's your view on that?
Michael, do you want to float it out, or happy to?
Sure. Yeah, I think masks are probably here to stay, and even indoors. And I think the reason for that is they're a relatively low impost intervention that we know reduces transmission by some amount. And so at least until we're in a situation where we're very confident we're not going to have a big surge of cases, the masks are going to hang around in these closed settings. In terms of alternative modelling, suggesting a peak sometime near Christmas, I think we've seen all the modelling that's come out has a lot of uncertainty around what's going to happen and when, and trying to predict exactly when a peak will happen is very difficult. I think we can be pretty settled on the fact that in Victoria and in New South Wales as well, the case numbers are going to continue around a level that they already are. And so that means the hospitalizations and things will continue on as well. Very hard to say when they'll peak. It's probably a while away though yet.
I'll just add, I think what's really important here to consider, it's as true for the Doherty work as the Victorian roadmap work from the Burnett and any other work, is that over a period beyond about a month, epidemiological modelling is really giving you a list of possibilities and scenarios, as opposed to predictive forecasts in the sense of like a weather forecast where we're making a quantitative prediction. And so I would be, I think it's important to interpret those sorts of results in that context of if the settings, you need to look at all of the assumptions that are stated in any modelling, in the Doherty modelling or any other, and say, if this happened and if this, then we may see a peak, say around Christmas. But all the national plan and the way that the states have responded throughout this pandemic is a responsive and adaptive one, as Jody said at the beginning of this forum, which is that if restrictions are eased and cases, to say, started to grow faster than we expected, we would be measuring it and we would be advising, and I would hope the governments would respond to manage that epidemic in a way that kept hospitals within capacity and minimised the number of infections and cases and hospitalisations and deaths into the future. So that if this virus, say, surprised us or acted in a way that we weren't expecting it to, or that was sort of unlikely, that we would respond accordingly. So I think it's very important with any of the modelling that's out there, including from us, that it's always seen as a scenario. There's only a few bits of work over a very short horizon period, which you should be considered as quantitative forecasts.
Thanks, James. We'll go to another written question now from Chip Legrand from The Age. He's asking, when the Doherty Institute originally modelled the national roadmap, it assumed the Delta variant had the same virulence as the Alpha strain. But the Burnett Institute modelling released yesterday for Victoria adopts the Fishman and Achute, I'm hoping I've said them right, modelling from the University of Toronto, that Delta is twice as likely to put you in ICU as Alpha and other variants of concern, and 1.5 times more likely to kill you. So has the Doherty Institute changed its view about the virulence of Delta since the roadmap was released, and how significant is the difference in the Doherty and Burnett assumptions?
Freya, do you want to speak to this one?
Yeah, so in work going forward, we would be using more recent evidence that's emerged since the original modelling was put. Parameters were chosen for this tranche of work. So, and yes, that specific paper is one that is a part of an evidence review we've done in the last month that we would be incorporating into our analysis going forward.
I think we should just be incredibly clear that at the time that the Doherty work was done, it was very clear that Delta spread more quickly, and that is, of course, incorporated in the work. But the evidence that Delta was more severe in terms of clinical outcomes was either scant or certainly unsettled in the international community. And so we made an agreed and very deliberate assumption that it was alpha-like there. And of course, as scientists, we update our understanding based on available evidence, and it's now far more clear that Delta is more severe, and so work and say forecasts, so talking about forecasts again, forecasts of potential hospitalizations when we get to that stage would account for the increased severity of Delta. So we always are updating our views and updating our advice accordingly.
Thanks, James. We'll go to Josh Butler, who's got his hand raised now. We're just unmuting you, Josh, and go ahead.
Thank you. Thank you for doing this. I'm Josh Butler from the New Daily. I wanted to ask about TIQQ. Obviously, in the modelling, it shows a very big difference in cases and deaths when TIQQ is partial versus optimal. We know that they're modelled on, I guess, the efficiency of New South Wales and Victoria's systems from last year. But I think since the modelling has come out, both those states have basically said, and the ACT as well, that they might not be able to get back to 0 cases. Therefore, they may be no longer contact tracing to 0 anymore. The question I wanted to ask is keeping Australia's TIQQ at those optimal levels realistic at this point? Can that mark actually be achieved from where we are now, or are we better looking at the modelling of the partial responses? I mean, some epidemiologists have suggested that TIQQ could even be wound back here in Australia, that there might be less time spent in isolation, maybe getting rid of exposure site lists. People are less inclined to get tested if they feel they're fully vaccinated, those sorts of things. Is optimal still even an option at this point, do you think? Can we get back to that level?
So I might just frame that by saying, part of the point of the sensitivity analysis in thinking about these scenarios with high caseloads was saying, okay, if we only have partial TIQQ, what's the additional overlay of interventions for control? So that was, again, in thinking about what might an adaptive strategy look like, giving some of that response. But also the really important thing is that, and I'll let Nick or Freya, as they wish, talk more to about it than this, is that what we were modelling was not specific response actions, and we have seen dramatic escalation of case and contact tracing and the definition of a close or casual contact over the last 18 months beyond any previous infectious disease. So it's really a time to evaluate value. So from there, I'll let you guys fight over who takes it next.
Nick can start.
I got there first. Look, I'll just, yeah. Oh, I forgot what I was going to say. You better go, Freya.
So I guess the thing is, the point about value is important because we've seen even in the last few months, states that have had higher caseloads have been adapting and changing their strategies and trying to find efficiencies in the way that they do TIQQ. And so that can mean, and we're looking at that more closely now, so we probably can't give you a very strong quantitative answer, but the point is that there's probably ways that we can achieve similar levels of reduction in infectiousness with different strategies that are more efficient, basically. And so that's not, so there's sort of, and we're sort of, states and territories have been doing that as they've had to manage higher caseloads. They have naturally started to think about how they can do things differently going forward.
And I'll just add to that for a lot of states, what contact tracing has not been about reducing transmission per se. It's been about reducing the probability that there's one leftover case out there. And that's a very different situation. So literally hundreds of contact tracers assigned to one case to run down many, many different contact of theirs and contact of contacts and all sorts of things. Those are all things that are very labor intensive. And whilst they help with that aim of getting to 0, that's not an efficient use of resources for when you just want to get the majority of people into isolation before they can start spreading. And so if you can accept that you can miss a few, then you can target your resources to get far more people into isolation earlier. So there's definitely a lot of space to do that. Obviously, it's kind of Victoria and New South Wales have some experience with dealing with large caseloads and having to change things, New South Wales in particular recently, but there's an ongoing conversation that we're a part of, supporting with some modelling to inform exactly what those different strategies are going to look like. And so the public health units across the country are working really hard to do that.
Thanks, Nick and Freya. The next question will go to Rick Morton, who also has his hand up. So we'll just unmute you, Rick, and go ahead.
Hello, Rick Morton from the Saturday paper again. There's a line in the report, the updated report, that says our future assumptions about TTIQ effectiveness will be based on current and ongoing consultations with all jurisdictions about devising future evidence-based public health actions that are demonstrably effective and sustainable. Is that like cheeky modelling speak for saying that states have been doing things that just don't work, maybe curfews or mandatory outdoor mask mandates?
No, it's really back to this TTIQ discussion, Rick. And like when your objective is stamping out every last thing, you are going to do absolutely everything. But in rescaling the objective to transmission control, you work out what you can scale back that had a very low yield. So it really is this process of evaluating and reviewing the evidence on what the gain was of all of these rings, concentric rings of contact tracing, and thinking about the effort involved in each. And then, with that, with the jurisdictions working out more efficient and sustainable processes going forward, because we know, we can't keep tracing at that level forever. So it really is with a resharpening of objectives and focus, let's use the evidence to develop something that we can believe we can keep doing into the future. Does that make sense?
It does. Thank you so much.
Not only something we believe we can keep doing, but something that we believe is sufficient to achieve the goals of the plan.
Thanks, James. We'll jump over to James Pearce now from Pharma in Focus. He's asking, would your advice be to focus on lower case numbers rather than higher vaccinations when removing restrictions? Should the message be that vaccinations will lower case numbers, and when the case numbers are lower, restrictions can be eased?
Michael, I'm going to let you have a go at that.
James had such a good reaction. I was thinking he should have a go at that. They're almost one and the same. The higher the vaccination coverage, the lower the cases will be. But the other thing that will change as vaccination goes up is the percentage of those cases that end up in the hospital system will be much lower. And really, it's the objectives changing from trying to keep numbers as low as possible to keeping hospitalizations and thus severe outcomes like death as low as possible. So I would be tempted to keep the focus on vaccination coverage. It's definitely the thing to push forward as fast as we can. That in turn will naturally reduce case numbers. And when those case numbers are reduced, the restrictions will ease. So they all form one piece of the puzzle.
And I'll just add to that, the first piece of work we did was actually in partnership with Treasury, who have released their own report. And it was the joint position of Health and Treasury that keeping case numbers low was good for health, but it was also good for the economy. It meant that we would be in a more stable position. Treasury gave the example of the US, where they didn't want to have restrictions because of the economy, but at high caseloads, people were too frightened to go outside, and anybody who could self-isolate did. And so you get other implications. So this low case strategy sort of ticked all the boxes in terms of a stable future, but also having the best economic outcomes for Australia as an overall strategy. So that remains an objective, and I think that's where we're still seeking to land.
Thank you. We've got a couple of follow-up questions now from Daniel Sutton. A quick follow-up question on New South Wales. Given the current number of cases in New South Wales, do you believe medium restrictions should be in place between 70 and 80% double dose? And does the New South Wales 70% plan, where cafes, bars, shops and homes are open for the vaxxed, actually meet the definition of medium restrictions?
Who wants to pick that one up? Do you want to do that one, James? Or, I think we've talked a bit about what our HSMs mean.
Yeah, so we've already talked about the fact that the effect of a bundle has been measured by Nick Golding and the other members of that part of our team. I think so we can't comment directly on that. I can reiterate that we will continue to measure things. The restrictions in place in terms of those events being accessible to vaccinated people does, which is not part of any of the work that we looked at. Like that does materially reduce risk. It doesn't eliminate it because people with the vaccine can still get infected. It's just less likely, and they can, if they are infected, pass it on again, almost certainly less likely. So that is, it's the policy to me is broadly an appropriate one in that it's not just reopening. It's saying that there are a stepwise set of things. However, others might want to comment here as well. My main view on this is that we need to just keep measuring and monitoring the situation, particularly at a sub-regional level, which is in place. That to me is by far the most important aspect of this, rather than is that compatible with some abstract scenario or not.
Did anyone else want to jump in? Or we're all happy? All quiet, excellent. We'll go to Andrew Huff from the Advertiser in Adelaide. He's asking, last week SA authorities raised the idea that it would need LGA areas being at 80% compared to the whole population. Is that the assumption the modelling has made? And could you explain what is better to avoid COVID waves?
Michael?
So it's not an assumption that we have made as part of this modelling package. We've assumed that Australia is one large package of people here, but we do know that these small area effects at the LGA, and even much smaller than an LGA, are important for controlling transmission and stopping these small outbreaks turning into big ones. Couldn't say off the top of my head whether that strategy would work better for stopping future waves of COVID or not. It is something that could be thought about, but I think you probably need to go deeper than the LGA level to really understand the impact that sort of thing could have there.
Thanks, Michael. We'll go back to Casey Briggs now. Casey, we'll just unmute you and go ahead.
Thank you. Thank you for taking a second question from me, Casey Briggs of the ABC. So we're seeing a case curve in New South Wales that is consistent with the findings of your model, the original and the updated one. And broadly speaking, it's a picture where the PHSMs have not changed all that much. What has changed has been the vaccination coverage. So that is a consistent picture of the transmission potential seeming to be below 1 now. I've been careful not to ascribe causality there, but I guess my question is, why can we ascribe causality there? When we look at Victoria, which is in a sort of similar situation, maybe set back a few weeks, is there any reason for us not to think that when that vaccination coverage reaches the sort of level that it's at in New South Wales at the moment, which it maybe is only a week or two away from that we wouldn't see a similar situation?
James, do you want to talk to that? And
I'll say something high level, and then I think Freya can speak as well. So Casey, it's an excellent question, and it gets to the heart of what a team of us do every week in a situational assessment. I assume you're familiar with the Commonwealth Health Common Operating Picture, which reports each week the reproduction numbers and the transmission potential as measured in each state and territory. That is work conducted by us. And in that, if you monitor the temporal trend in the transmission potential through time, so if you take each common operating picture and stack them up side by side, you can see a slow and steady decline in the transmission potential in New South Wales, and that's almost entirely due to the vaccine rollout. There's probably been, and Freya or Nick can comment, there's been some small changes in behaviour and mixing within New South Wales that will have also contributed to a decline over the last month a little bit, but it's mainly and predominantly a vaccine effect. We're seeing the transmission potential reduce in Victoria as well due to vaccine. It's just a little bit higher for two reasons there. I think the vaccine is just, the rollout's a little bit behind in Victoria compared to New South Wales. Still doing pretty well and increasing quickly, but not as high yet. And there are some slight differences in Victorians' mixing behaviours compared to those in New South Wales. But yet I would anticipate that over the coming weeks, Victoria's transmission potential will get very close to 1, if not drop under 1. I don't have the numbers in front of me, sorry, but you'll see them in the common operating picture. And with that, it makes control just that much easier. And that would also then help us manage and reduce infection in the active cases, which we would expect to mean that the actual reproduction number, I'm getting a bit technical here, would also come down with that. Freya or Nick, any other comments?
Sounds good to me.
Okay, sorry, I gave a longer answer instead of an opening answer.
Can I just very briefly, one tiny follow up on that?
Yeah.
What we're seeing is in both New South Wales and Victoria a sort of gradual and steady decrease in that, effective reproduction number, transmission potential, rate of growth, whatever you want to call it, however you want to measure it. Is that consistent with vaccinations being really the primary driver of change in transmission potential right now?
Yes. I'm happy to say yes. Yep.
And I think there's also useful synergies there. So, one of the big areas, so for example, in Southwest and Western Sydney, one of the issues was there were high essential worker populations who therefore weren't protected by the social measures because they had to go to work. By targeting vaccination at those people, you actually get a synergy, because the people who are actually mixing are then more likely to be protected. So, it all makes logical sense, but I think it's the kind of storytelling that we need, and bless you for saying that, it was a sign that our modelling might be vaguely useful, that actually the vaccines are there to do something, and we need the public to have that confidence that what we're saying is they will start to do the heavy lifting and mean that we are less likely to see things really spiralling out of control, which is why we've had to go to lockdowns at such an early stage of cases, in an era when we did not have anything else to hold the population. And unlike lockdowns that act while they're on, vaccines keep acting. They change the population characteristics. They provide ongoing protection in a way those other measures don't. So, that's all where, we have the potential to move into a more stable situation where, hopefully we can start thinking a little bit beyond 2 weeks at a time. I think many of us who've lived lockdowns for a long time are very, very much looking forward to that.
Thanks very much, Jodie. We've got 2 last questions from Heather, and then I'll go to Sarah. Heather's asking, vax rates in the 12 to 15 age group are not included in the current targets, but uptake has been significant, with 20% of kids in New South Wales in that age range already having their first dose. Should they count towards the 70 and 80% targets?
So I might have a go. So the reason, when we first did our modelling, there was a lot of discussion about the fact that we modelled 16 plus vaccination. At that stage, that was the age eligible population. Nick maybe can speak more to the fact that when we looked at at adding 12 to 15-year-olds over and above that at the whole population level, they made a relatively smaller contribution. So at this point in time, if we have vaccination rates tracking with 16 plus population at the target percentages, anything else is a bonus, but it's obviously more of a bonus in the environments where children mix. And in terms of thinking about reopening and getting back to school and making face-to-face learning an ongoing expectation, rather than, again, those of us in Victoria, whose kids have been, homeschooling for most of the last 2 years, clearly, that is a really critical goal in terms of achieving other social and economic benefits of immunisation. But Nick or Freya or others, if you wanted to say more about that, please do.
Yeah, I'll just clarify. It's not, it wasn't a particularly surprising result to us that adding on the 12 to 15 kind of vaccination coverage when you've already got high coverage in adults wasn't surprising to us when we got that result, that it didn't have a huge effect, because we know that, this is the thing that surprised us about COVID when it first emerged, was that it's surprisingly unable to transmit among kids. They can transmit it, but the numbers are much lower, naturally. And also that 12 to 15 age group is quite small. It's only 4 years. So that on its own doesn't make a huge difference. And also, once you've vaccinated the parents of those kids, because they're not particularly able to transmit to one another, because they're both less susceptible and less infectious when they're infected. Because of that, you don't get that much transmission in schools. You don't really get sustained transmission in schools in the same way that you do in workplaces. So a lot of kids that we see getting infected are getting infected by the parents in the home. And so in our simulations where we've had high levels of adult vaccination coverage, their parents are vaccinated. And that means they're less likely to get the infection in the first place. So it all kind of adds up, that it's not entirely surprising that that 12 to 15 age bracket contributes a lot to the national transmission rate. But that's not to say it's not worth doing, as Jodie has said, and every little helps. And I guess one argument for not including them into those kind of targets and thresholds, and I should say that defining policy targets is not our job, but the fact that people are, kids are very used to getting vaccinated and also very keen to get their kids vaccinated, I suppose is one reason you might not actually want to include them in the target, because it's probably going to happen anyway, hopefully.
Thanks, Dick. And a lucky last question that we have is from Sarah Martin. So Sarah, go ahead with your question.
Thank you very much. And I forgot to say earlier that Sarah from The Guardian. I just wanted to ask about the model's assumption of even vaccination coverage. Obviously, we know that's not the state, the state of affairs either sort of between the states and within the states. And so I just wanted to ask what the consequence of that is if you have one state that's reached 80% opening up and allowing, freedom of movement and so on, while other states have lower vaccine coverage and aren't open. And I guess the consequence within the state, there's been a lot of talk, for example, about Byron Bay having only 30% vaccine coverage. What's the consequence in terms of the outcome for case numbers and deaths? Are we going to see that, sort of pandemic of the unvaccinated and see those areas where vaccine coverage lower really bearing the brunt of those case numbers? And I guess why does the model assume that when that's not the case?
I might take that one. So the first thing is, the model was deliberately a high level abstraction to just say, in an even situation, it was about comparing outcomes at different levels of coverage. The more variability and heterogeneity and other things that you built into that initial framing model, the more complex and uncertain its outputs would be. So often in modelling, we start with something very simple to determine what the sort of key principles are or the way in which a system operates. And from our very first reports, we said, in real life, you're going to have to pay attention to the detail because this will all play out at the local level. So we've talked a lot about spot fires and multiple fronts, and everybody loves a good bushfire analogy. But, so it's the difference between the purpose of a model, which is to help make a strategic decision. And then, as we get down into things like looking at local monitoring and situational assessment and forecasting, we're going to see more and more of these things play out. And, people are more and more interested in understanding what's happening at a very local level. And we already know that public health units and responders direct their attention to where things are happening. And that's how that will augment, I guess, what it is that immunisation has done. It's certainly prompting enormous effort and investment at the moment in addressing local barriers to access, which is most of the reason that people might not be immunised at this point in time. Hesitancy is part of the story, but making sure that everybody has equitable access and is able to be immunised is really critical here. But then, in situations where people choose not to be immunised or where there are low areas of coverage, those areas will remain vulnerable. And so it's very important for public health units to know that. It's very important for health system preparedness to make allowances for that. And I think it's just really important for people to consider their place within a community in making decisions about risk, that those decisions are not restricted to themselves.
Thanks very much, Jodie, and well done, everybody, because you've managed to get through to the end of the questions for our briefing today. So I want to thank all of our modelers for joining us for this online event. I know I found it incredibly useful and interesting, and I think the journalists online have as well. So thank you very much for your efforts in answering those questions. We will put a recording of today's presentation on our website, cimex.org, shortly. So if you want to listen back to any of the answers, you can go there and download a copy of the recording. If you have a follow-up interview request with any of our speakers today, they're all going through the communications team at the Doherty Institute. So that's Rebecca Elliott, and her number is 038344 848360, or her email address is rebecca.elliott@unimel.edu.au. If you have any other inquiries at all, you can give us a buzz at the Australian Science Media Centre. We're on 08 7120 8666, or you can email us at info@smc.org.au. Thank you again to everybody for joining us today, and we'll see you soon.
Thanks so much, Lyndall. Thanks, everyone.